We're live with, I'm just going to say Dr. Thor because I always have fun trying to pronounce your name.
Just call me Thor.
And so, you know, we, last week actually, we were actually at a webinar, right? We did, we were on the PRRT panel for NANETS, where we went through a bunch of different questions. We had some surveys that were interesting as well, and we worked on a paper together on PRRT. And since a lot of these things were on misconceptions and challenges in PRRT, and this really wasn't a event for patients, I thought we should still ask or go through some of what we went through as well last week. And I'm going to share, I think, a tab here somewhere, if I can find it. And all right, so this was one of the first questions that was asked in the survey that we did, and I always find this interesting because I don't think patients and providers really know that the first phase 2 trial for PRRT was done as an international trial with 18 centers, with 15 of them in the US. And I know Dr. Odoricio was one of the lead investigators on this back in 2001, which I think surprised people. Did you know about this trial?
So I was aware of it, having worked in Iowa for many years and with Dave Bushnell and Odoricio.
And I know when he published in 2010, he was pretty proud of finally getting it published as well. And the next question that was kind of asked was how long before PRRT was approved in the US or in Europe over the US? And again, most of the participants felt that it was approved more than 3 years before, and we've talked about this before. It was used as compassionate care, and the approval was really only a year prior to it being approved in the US, which was fascinating as well. And then lastly, where the actual isotope comes from, and it's actually, while it's manufactured, while it's labeled in New Jersey, it's actually manufactured in Iowa, of all places. No, not Iowa, I'm sorry, Missouri. You're Iowa.
Yeah.
But let's get to the questions, which I think are really the important part. And I'll, let me filter and get to what I wanted to see here. And, you know, lots of questions came in as to different, and I'm actually changing the what's going on here in 1 second so that we get this right. You know, one of the talks, and certainly you highlighted this in our panel, going beyond just 4 therapies with PRRT. So do you want to discuss a little bit about that?
Yeah, so for this, additional rounds of PRRT beyond the standard 4. So as you may know, so the FDA approval is for 4 treatments with lutetium-177 dotatate or Lutathera. And although it is sort of biologically, it makes biological sense to continue the treatment beyond that, and even give lower doses more frequently. It hasn't really been studied, and it wasn't really approved in that way. So I view that as something that's still experimental. Definitely something that I think needs to be studied. There are some thoughts that the multiple or more doses with smaller, actually more treatments with smaller doses may end up being more effective. But I think we just need more data. We need better studies to say that that is the right thing to do.
Right, and certainly there were a few papers presented at NANETS as well about that, as well, that, you know, had the discussions that it was either 18 months post or a year post or post first treatment. that if you were stable for that was what they were starting to look at as well.
Yeah, so that's actually, so just to clarify, so there are these, so actually I may have misunderstood the question a little bit, because there were actually two things here. One is, should we do more treatments in the first line, or should we do retreatment? And retreatment, as you rightly said, is definitely something that we should consider for patients who've have gone more than 12 to 18 months from the last treatment, especially if they had a good response to the first round. So retreatment is something that we now fairly routinely do.
So the next question kind of in this who can be treated area would be determining when to use, right now we have an approved therapy of LU-177 dotatate. We also have alpha trials. We have a bunch of clinical trials, whether they're with alpha, whether they're with other radiosensitizers or other, PARP inhibitors and things like that. How do you determine when it's the right time to, use what would be standard therapy versus go looking at some of the clinical trials?
So my take on the combination of lutetium-177 dotatate PRRT with something else is that it should be done in the context of clinical trials. And so there is certainly substantial experience with combining PRRT with chemotherapy. That's probably most commonly done, but also a lot of interest in combining it with immunotherapy and with other drugs such as the PARP inhibitors that were mentioned. I personally think this should not be done outside of a clinical trial. And indeed, we're starting to get some results from Australia, and it is not clear if the combination of chemotherapy and the PRRT is really better than PRRT alone.
Okay, and I know there was some conversation that we had about using this with G3 nets, with well-differentiated G3, not poorly differentiated, but thoughts on that and trials that are going on in that space.
Absolutely, absolutely. So, G3 nets, or grade 3 neuroendocrine nets, are a difficult group to deal with. So if you look at the G3 neuroendocrine neoplasms, so now we call them J3 NENs, so that is actually a group of very aggressive tumors and a group of much less aggressive tumors combined within one group of G3 neuroendocrine neoplasms. So the well-differentiated G3 nets, they can definitely be treated with PRRT. There is fairly convincing evidence of that being the case. The poorly differentiated neuroendocrine carcinomas are much more aggressive. I am not convinced that PRRT really is effective there, and should definitely, in my opinion, shouldn't be done unless it's done on a clinical trial. As for ongoing trials, there is an ongoing trial, NETTER-2, which will allow patients with grade 3 well-differentiated neuron tumors with Ki67 above 20, maybe all the way up to 50 to enroll. And there may be another trial coming down the pike as well. So G3, well-differentiated G3 nets, PRRT is definitely a consideration. Poorly differentiated G3 NECs would not do unless on a trial.
Just keeping kind of in that the other conversation we had, and certainly we had Dr. Hope on our panel last week as well, was looking at the LungNet group.
Mm-hmm. So LungNet, yeah, okay.
Yeah.
Keep going. Yeah.
No,
so do you want to hear about the LungNets? So really the key with the LungNets is, again, to confirm that we're dealing with well-differentiated lung neuroendocrine tumors. So some neuroendocrine malignancies of the lung are poorly differentiated high-grade tumors, most commonly large cell and small cell lung cancers. Those should not be treated with PRRT currently, and ideally, if that's done, should be done on a clinical trial. As for the well-differentiated lung nets, typically known as either atypical or typical carcinoid tumors, those can be treated with PRRT, assuming there is activity on receptor imaging like dotatate PET. And as long as they light up on the scans and they're well differentiated, I think they can be treated. There are not large studies yet, but there's substantial evidence from looking back at large groups treated, as well as what's called phase 2 studies, where PRRT seems to be effective. So yes, well differentiated lung NANETS PRRT should absolutely be considered.
That's great. And I know one of the things that you certainly have done some work and study around was, you know, we talked about this on the call as well, was kidney function. Both, I thought it was interesting. Dr. Hope brought up working with patients who are on dialysis as well, but you know, limited or other types of kidney function issues and how that goes forward with people with PRRT.
No, so kidney function obviously is somewhat of a concern to us. So, and this goes back to earlier studies of PRRT, mostly with Y90, Erythrium-90, that was in some patients toxic to the kidneys. So the lutetium-177 does not seem to have much, if any, meaningful or real kidney toxicity, although we're always careful. So the concern has been more that if you have kidney problems and your kidneys are not working right, the radioactive chemical may hang around in your body for longer, because that's actually how the body gets rid of it, by flushing it out through the urine. So the thought is that it might actually stick around for longer and cause more toxicity, mostly in the form of lowering your blood counts. Well, that does not seem to be that much of a concern either. So I think we can treat the people with moderate kidney dysfunction. We can treat with PRRT. We and others have substantial experience with that now. The toxicity does not seem to be increased much, and we will have some data coming, I think, fairly soon on that. As for the more severe kidney problems, that should only be done after really considering all other treatment options, and ideally working with a nephrologist or a kidney specialist who can help out with it. As for treatment on dialysis, it's been done, and there have been a few cases in the US where this was done, several cases in Europe as well, and so it's doable, and we just have to be really careful with the machinery, how to handle the radioactive fluids and things of that nature, but all of these things can be done. But the experience with patients on dialysis is very, very small.
The question about upregulating somatostatin analogs for those that don't have any or have very low receptor positive cells. So thoughts about that?
So I can speak to it a little bit. So I would like to actually, I should have looked at that presentation again, but this has been looked at by some of the groups in Europe, including the group in Amsterdam, I believe. And you can actually potentially upregulate the receptors, essentially bring more receptors to the surface of the tumor cells by giving somatostatin analogs. And intriguing early data, whether that is enough to make PRRT work better or work where it otherwise wouldn't have, I think remains to be seen, but definitely something that is of great interest to us.
One of the things that certainly patients are told often was that when you feel pain, it means that this therapy is working. With the converse being, if you don't feel pain, maybe it's not working. And I just want to, since I find this to be a misconception that pain has pretty much nothing to do with it. But what your thoughts on this question?
Yeah, so absolutely. So I'm not aware of any studies that have really conclusively shown that the pain is necessarily a good indicator of a response, meaning that people with pain are more likely to respond. But we've seen pain quite a bit in patients with, especially with extensive metastases after PRRT. And the thought is that the PRRT, as it starts killing the tumor cells, it starts this inflammatory process. So it is logical to think that pain may be an early sign of a response, and I think that deserves to be studied. Like, I'm not sure if that is the case, but on the flip side of it, the absence of pain does definitely not mean absence of benefit. So we have seen multiple patients who have sailed through the treatment with no pain whatsoever, and many with a good response. So the absence of pain does not exclude the benefit. So yes, we will probably will be looking at the pain as well.
And I know one of the things that I've seen and heard with patients is that they've been told not to consider PRRT because it has a low overall response rate as opposed to other therapies. And do you want to discuss a little bit about ORR versus stability versus other therapies that someone might be taking?
Well, absolutely. So we know that the response rates of PRRT are probably somewhere in the order of 20 to 35, 40%, but a lot of it actually boils down to how you measure the response. So if you're in a clinical trial, there are actually somewhat strict criteria that we follow to decide if a person is responding or not. So essentially we measure a few tumors, a few lesions, and then there has to be a certain amount of shrinkage for that to count as a response. In cases where there is somewhat of a response, but not quite enough to meet that criteria, on the trial, those patients would be called a stable disease. Essentially, they did not have a partial response. But those patients may benefit every bit as much in terms of having stable disease for longer. And sometimes I tell my patients that at the end of the day, we're not necessarily trying to shrink the tumors. So we're trying to keep the tumors from growing. And that is particularly important in patients who don't have symptoms from their tumor. So we're just trying to keep it from growing. I would much rather see someone go 3 years with no tumor growth after PRRT than someone have a really great response where everything got smaller, but then 9 months later, things are growing again. So stable disease is not bad.
Right. I mean, there are certain instances where you may think that you need to have you're looking for a response, or you're looking for shrinkage, and that is probably more important than stability at the moment. But it's I kind of describe it as doing multi-dimensional chess. It's like there's not just one answer, there's multiple answers, and you have to decide which dimension you want to play in, and that ORR isn't the only one. And it may be for just a moment in time, but there are other things like being stable and having a good quality of life for a long period of time. This is back to, kind of a PFS question, but also some confusion that's in there is, we have a long PFS. Does that mean the drug's actually active during the entire time you're PFS? Or is something else going on? Because, this is a radioactive substance that's only really effective for 5 or 10 half-lives.
Absolutely. So the radioactivity is only there for a few days, and actually, if you look at the radioactivity in the body, it's actually shorter than that, because a lot of this drug is being eliminated through the urine while still radioactive. So essentially, within a week, the radioactivity has or left the body, or at least that the activity that's needed for the treatment, but the damage to the cancer cells has been done. So the radioactivity, as it gets in close proximity to the tumor cells, causes DNA damage and sets off this process of sort of destruction within the tumor cells, or in some instances, not necessarily destruction in terms of shrinking them, but at least keeping them from growing. So the activity, the PFS, can linger for years, even though the radiation treatment is long gone from the body.
Right, and can still act as the body cleans up dead cells, right? And you can have regression for many times into it, and often we're not seeing it on imaging for months or even years past. So it's something else that's going on.
Absolutely, and actually, I might want to jump in there because it's the first patient I ever had on PRRT was when I was at the University of Iowa, and so that person went to Switzerland, to Basel, and got 3 treatments with yttrium-90, which was done commonly back then. And the first CT scan looked a little bit worse, and I got a little worried. The second scan a few months later also looked a little bit worse, and then I emailed the people in Basel and said, I'm a little worried about this, and they said, well, these changes are subtle, just wait and see what happens. The patient was doing great. Then the next 3 or 4 scans all looked better. Each scan looked better than the one before. So this actually was happening 8-9 months into it, and so then I've been paying attention to this, and I saw a person in May this year who had her last PRRT May in 2019, and a year from the last PRRT, the scan was still getting a little bit, the tumors were still getting a little stronger. It's just smaller. Tumors were getting smaller, so they were sort of set on this destructive path that just took them forever to die.
No, I mean, look, in my own personal case, my retreatment, 3 years into it, I was still showing reduction of disease, scan over scan. And clearly it had nothing to do with the radioactivity, nor any other thing that I was taking, because I wasn't even on long-acting somatostatin analog, which I might as well get to that question. What is the purpose of long-acting somatostatin analogs? And, there's 2 parts to this question. We have some actually providers that are telling patients it seals in the radioactivity, which is an interesting thought, and probably not a correct thought, but I'll let you comment on that. And, talking about competition of therapy, the hot therapy versus cold therapy, when do you give that somatostatin analog shot, or does it matter, and why do we do this? But the first question is, does it seal in radioactivity?
It does not seal in the radioactive or radioactivity. So this obviously is I'd say probably one of the most important questions in what I call post-PRRT therapy now. Should you continue long-acting somatostatin analogs? And we don't have the quality trials that we should have. But we do have studies, including one study from Germany that looked at patients who got PRRT, and they looked at those who stopped the somatostatin analogs and looked at those who continued somatostatin analogs. And those who continued, they went much further without tumor growth, and they also had better life expectancy. But there's a lot, it was not a randomized study, so there's a lot of potential, what we call confounders, so other things that could have played into why the treatment was stopped in this person but not in that person. But it's something that I think needs to be studied. As for, so I most of the time continue the somatostatin analogs. I am still very careful about having at least 4 weeks from the last injection until the next PRRT following the FDA approval, or the guidance provided therein. And but there are some intriguing data coming from Europe saying that if you can upregulate the receptors, you might potentially augment the efficacy of the PRRT by giving a somatostatin analog before you do the PRRT. Something I think deserves being checked or tested in a clinical trials. Right now, what I typically do is to continue the treatment, no somatostatin analog within 4 weeks of therapy, and then you typically right after the PRRT, I give a dose, and then 4 weeks later, and then have them come in for the next treatment. So I continue it during and after in most patients.
And when you say right after, do you mean 4 hours post delivering therapy, or the next day?
Yeah, so I typically offer my patients to get it 4 hours after therapy. So so the patients can just complete their day and not having to worry about it. Some people have been spending 2 days here and it's been a long day. They just want to go home. And then I just talk to the local providers about maybe getting it done within a day or two. So leave it up to patients. A lot of patients are actually taking us up on the offer of doing it 4 hours after the treatment and just be done so they don't have to check in with their local doctors a day or two later. They can just go home and rest.
And I think there's a lot of confusion with what SUV means and how SUV plays into therapy, and does it really mean more than just how we select for therapy, and does it actually show response or progression or regression? And I know that we use it for selection therapy because obviously if you're not receptor positive, this is not going to be an effective therapy. But we have people who are either using it as a measurement for, I have a higher SUV, hence therapy might work better, or my SUV went up or down, and that means I'm progressing and regressing. And you want to touch on that one as well?
Sure, I can. So not being a nuclear medicine specialist, so my knowledge is somewhat limited. I freely admit that. But there are data from the Netherlands showing that the brighter the tumors are, the more of a response you will have. And then there are some studies that say that the more of a response you have, the longer progression-free interval you will have. So I think more SUV is, in terms of PRRT efficacy, is probably better. But and you have to have some activity, otherwise the drug won't work. As for selecting patients for therapy, we don't know how much this matters. I think I know I keep going back to the answer of this needs to be studied, and that's actually what needs to be done. And so the brighter the better in my mind. But then even if it's not that bright, it can still work. As for measuring response, here you can ask different nuclear medicine physicians, and each will have their take on this. I don't think the SUV is yet ready to measure efficacy. That may change over time, but we actually typically don't even do nuclear imaging for a year or two after PRRT because we don't know what to do with the information, and we don't really know if it means anything.
Yeah, I certainly talked to enough nuclear med docs as well that SUV is just measuring, receptor density, which can be changed by when you had your last somatostatin analog shot. So that there's so many different ways to look at this possibility that it's not necessarily has anything to do with what the current response is. It has to do with just what the receptor density is at that such matter of time, and that it really isn't a measure of progression or regression. Even if a cell is losing receptor, it doesn't mean that it's regressing. It just means it's lost a receptor, and you may not be effective for therapy for at least PRRT. This is one of the questions that we talked about, and actually you and I kind of had some paper about this, or at least one aspect of this as well. But we talked about this on the panel last week as well. Why are there so much different in release instructions between centers, and what kind of caution? Dr. Hope has done such a great job of doing videos about this and explanations, but do you want to paraphrase some of what we learned?
Yeah, so well, with this, we've realized that there's a lot of differences in terms of instructions from one center to the next. And I think some of it is just based on what those centers have previously been doing with other radionuclide therapy. So we have typically asked our treated patients to not be around pregnant women and young kids for up to a week or even more, and then as for pets, I'd say generally safe. As for other immediate family members, spouses, and older children, safe, because the radiation only travels a few millimeters. So the risk is probably greatest in someone who is, let's say, someone who's incontinent, who has an accident, and in terms of being unable to hold on to the urine, and there's a spillage of radioactive urine on the floor, and that would probably be the highest risk. So, but for most patients, the risk is very low. But with radioactive chemicals, we like to be cautious. And I'd much rather be overly cautious and then later found out that we were maybe too cautious than being too careless and find out that we caused harm later.
And we certainly talked a little bit about travel in the poster we did on radioactivity, and how even though it may not be effective in still killing cancer or killing tumors, 2 weeks or 3 weeks down the road, it's going to be measured in your body for about 70 days, and you can still set off alarms in different places, even though it's not really active as far as something that's impacting your disease. You can still measure it, and I think people are confused about that. And what was the most interesting thing you learned in our little work on that poster?
So the most interesting thing that I learned is that and this is something that I didn't really realize, is that before that radioactive chemicals, they sent off this what we can sort of call like a signature or a fingerprint, but then the signature of the lutetium looks surprisingly much like the signature from plutonium, and plutonium can be used to make all sorts of horrible nuclear weapons, and you don't want people transporting plutonium in their suitcases across international borders, or really transferring it anywhere.
Or on their body, right? You don't
Yeah.
want to have a dirty
No.
bomb enter your country, or a tunnel, or
Yeah.
other places. Yeah,
Absolutely, and that's what I didn't realize, is that the detectors that are at these points can actually misread the lutetium, which gives off very, very harmless radiation to can misread it as plutonium, it can be incredibly harmful.
Yeah, and actually we're working on follow-up papers that will highlight different isotopes that can be confused for other things, because it turns out, I spent time with Homeland Security, that they're, while these things are good, but they're only programmed to recognize so many absolutes, and that it has to be interpreted by a field agent, and kind of interesting. You touched a little bit about when you did imaging, and why you do conventional imaging rather than nuclear imaging post-therapy. I mean, some people are getting their scans after each round or after the second round, and some are waiting till 3 months post. Any thoughts of when we might ever get consensus of this?
Yes. So here's what we do. And that may doesn't have to be necessarily the right thing to do. So we almost always scan before the third cycle. The reason for that is that we want to see if there is any tumor growth. I'm not looking for a response. I'm looking to see if there is substantial progression, not a little bit of progression, but substantial progression. So one of our radiology residents and one of our fellows is looking at this now to see if this ever changes anything. So my bet is that the scan before third cycle rarely changes anything, and if we find out it changes, if it rarely changes things, we should probably stop doing it, because there's just additional cost from it. So some say, well, complete the entire therapy, because it's known that sometimes the tumors can swell a little bit before they start shrinking. So the concern is that if you scan before the third cycle and things get a little bit larger, that you might actually abandon something that's truly effective therapy because you thought the tumors were growing, when this was more like an inflammatory response of the tumors getting just a little bit more swollen, if you will. So we use just regular CT or MRI imaging, because part of it is that I just like to measure stuff. I like to put a ruler on things. I like to measure sizes because those measurements are incredibly reproducible from one scan to the next, from one reader to the next, as long as you just let them know exactly what you're measuring. Nuclear imaging, I like to do about 4 to 6 months from the last PRRT, just to take a new, fresh look to see what is going on. Not sure what to make of that information yet. So I don't think it's absolutely needed, but I like to do it, and I know that a lot of my nuclear medicine colleagues like to do that. Scans before each cycle, absolutely not needed. So, and the other thing is that if you, let's say you're looking at 8 months of therapy, and in cancer we generally scan 4 to 6 months, and if you're doing PRRT and you're not scanning until the 2 or 3 months after the last treatment, you might be looking at close to a year with no scans. And for me as an oncologist, and it's just a little unnerving. I may find out with my own data here that we don't need these scans, but until we get that data, trust me, we'll get there soon. I keep scanning at cycle 3. So this was a long answer.
No, but it was an interesting answer, and I think one of the other confusing things for certainly patients and maybe providers, and I think you touched on it, was that, why don't we just do a gallium-68 PET CT because it has a CT? Why is, and I try to bring up that, the CT you get in a conventional imaging without having to bolt a PET onto it is something that you can measure with far more accuracy. And I think you brought that up in your previous answer. And do you want to highlight that? Because I think a lot of people are confused thinking, well, it has a CT, but it's not the same level of CT that you're going to get in in a conventional imaging CT only machine.
So then we're talking the CT with the PET CT, or
right. Yeah.
So the PET CT, a PET CT is really a combination of 2 studies. There's a PET study and there's a CT study. The CT study that's done with a PET is typically a very low quality CT. So it doesn't have, most centers don't give IV CT contrast, although some places do. The Europeans routinely do. And we, unfortunately, in the US don't do that. So, and without that CT contrast, if you're looking at tumors in the liver, you can't really measure anything with accuracy. So the CT part of the PET CT can be really hard to measure in terms of how many inches or millimeters have things grown or shrunk. And the brightness, as we talked about, we don't really know what to make of that. You might do 3 PET scans, and things may be a little brighter on that scan and a little brighter on that scan, and we don't really know what that means. But a good quality, what they call cross-sectional scan, CT or MRI, actually allows us to precisely measure things. That's why I am a big fan of old-fashioned CT imaging.
Or conventional. We'll just call them conventional, but that's all right. Old-fashioned is fine as well. And I'm going to close with this question because I know it's one of the biggest fears that patients have is both myelosuppression and leukemia and the risk in both of them. And is there anything we can do to prevent it, or are some of the things that we're looking at in, we talked earlier about alpha or other types of trials we're doing for PRRT looking into this, and just your thoughts on both the risk in terms of PRRT and vis-a-vis other therapies as well that are kind of on our plate, that are our options.
Yeah, so the myelosuppression, essentially reduction in the sort of suppression of the production of blood cells in the bone marrow, where the blood cells are being made. So it's common after PRRT, but let's actually try to separate things out. One thing is what I call transient myelosuppression. So a drop in your platelets, hemoglobin, or white blood cells that will then recover later. That's actually pretty common. And that may happen 10, 20, 25% of patients, and depends, and we don't fully understand why some are more susceptible than others. Sometimes it's people who've had chemotherapy before who are more susceptible. Sometimes it's people who had radiation before. But the more concerning is actually the development of leukemia leukemia or something that could later turn into leukemia. Thankfully, that is actually pretty rare. But the myelosuppression is common. It's hard to predict and it's hard to prevent. So you could prevent it by reducing the dose of the PRRT, but then you might actually be reducing the efficacy as well. But what we have run into now increasingly is that we can do 3 treatments, and then after the 3rd treatment, the blood counts just are taking a long time to recover. So there have been quite a few patients where we actually did not give the 4th cycle. We said, we're just going to stop here. Your blood counts are getting too low for us to be comfortable with continuing. We would rather just be able to treat you later with what's called retreatment or even retreatment. So the myelosuppression is common. Most of the time it recovers completely.
Great. And I just want to thank you for this. You know, we went through, I don't know, about 16, 17 questions. And I think that's great. And I'm going to give me about a second or 2 to stop the live stream and open up people's cameras. So give me a second here.
Fantastic.